My name is Timothy Terrell. I teach economics at Wofford College, which is a small liberal arts college in South Carolina. As a smaller school, we have about 1,400 students or so. I get to teach a lot of different subjects within economics, a number of different electives. And I enjoy talking about applications of economic principles. And you spent the first part of the week covering some of the essentials of Austrian economics, and here we're looking at an application of some of these things to an area that I think many of you would be interested in, especially given the radical changes that we've seen in healthcare policy in the last few months. I'd like to talk about a number of different things, and we've got a lot of material here. I'm going to refer you to some readings, some of which I had put down. You may have seen these earlier listed as suggested readings before you came in here today. But there's so much here. I think if I can just point you to a few things that you could go on from here and read, this could be just a starting point for so much that you could do within this area of health economics. Let's look first at pharmaceuticals and some of the ways in which government intervention has affected our use of pharmaceuticals. And of course, the pharmaceutical industry is an industry that is very closely tied to government regulation, and it's hard to really envision what a free market in pharmaceuticals would look like. It's what we have is so far removed from it. And in fact, that goes for any medical care issue. I was mentioning in one of my earlier talks about how we're sometimes, in discussing these issues with others who are anti-market, they say, well, you know, the United States medical care system is broken. And so therefore free market economics in medical care just doesn't work. Well, we don't have free market medical care in the United States. What we have is very far from it. So it's a bit frustrating for me to again have markets blamed for what's really a problem introduced by socialism in American medical care. Anyway, moving on. One of the interventions here is that drug companies enjoy these government-granted privileges. There's patent protection. If you want to look into intellectual property issues, there's a lot of material that's come out in recent years within Austrian economics. Just one name that comes to mind that I know this fellow has thought a lot about this, Stefan Kinsella. If you want to look into intellectual property, that would be one place to start. I know I saw at least one of his books in the bookstore downstairs. So that's one of the interventions. We have, through this patent law, we have barriers to entry that protects against competition. And then we have the FDA, another regulatory agency, almost 100 years old now, that has introduced other barriers to entry. And we'll talk a little bit about the FDA later on. Then we have these ordinary corporate protections. We have, and Peter Klein has given a talk on corporations and their role within society. But that also, in bringing corporate lobbying for regulation into the picture, we end up with a medical care, a pharmaceutical market that is very, very far from free, and it does not reflect what we would think of as a beneficial, market-oriented kind of outcome either. All right. Well, in some countries, the government acts as a monopsony buyer of drugs. That is, they are the buyer. In some cases, in the United States, we have a similar situation where we have the government will purchase drugs in large quantities for the big chunks of our medical care system that are under direct government control rather than more of a fascialism, as Tom DiLorenzo calls it, a fascialistic medical care. And Canada would be one example of a country that has a monopsonistic purchasing system for drugs. Now, it's easy to drive down the price, the dollar price, of existing pharmaceuticals by using this method. The pharmaceutical industry is one which has very high fixed costs and very low marginal costs. You spend billions of dollars developing some drug, and then after you've spent all of that money on the research and the development, now it costs you a tiny amount to reproduce that chemical formula in the pill or whatever the drug form happens to be. So if you have a government that comes along after the drug's been produced and you say, well, now we're going to drive down the price by bargaining down the price with the drug company. Well, yes, you can do that. What you will also do is discourage any future drug production, any future innovation. These fellows are not Austrians, but they do have a kind of a general free market orientation. And one of the things that they've said in one of their books, Miller, Benjamin, and North here, is that if you have a single government agency in each country acting as a monopsony buyer of healthcare services, individuals are either prevented from buying healthcare on their own or they're limited by government rules as to what they may buy. Like other monopsonies, these national health insurance systems force down the prices of the goods they buy, drugs, medical services, or medical devices, physicians and nurses' services. This reduces the quantities of those goods and services that suppliers will provide, particularly in the long run. The bad news is that less health care is provided. Now, there are advertising restrictions. Another intervention here that affects our pharmaceutical industry. If you have an existing drug and you discover a new use for it, then the FDA may decide that you can't sell the drug, you can't advertise the drug for that purpose until you pass a whole new set of approval processes to get the drug approved for that new purpose. Some companies will simply not find it worthwhile to revisit the approval process for a new use. And so the new use, whatever it may be, remains relatively unknown. One article, and I've got the website here if you'd like to look that up later, but new drugs do consumers no good if they don't know about them. Advertising is not a social waste. It provides information, valuable information. So advertising restrictions imposed by the FDA prop up the profits of incumbent drug marketers at the expense of newcomers in the industry and consumers. Now, this has been particularly interesting to people who are into some form of alternative medicine. If you want to enjoy some alternative approach to dealing with your healthcare problems, the FDA may put barriers in your way. The aspirin case is a good example of the alternative use and what's happened with advertising for some new purpose that's discovered. In 1988, at a meeting in the offices of the FDA commissioner, all companies making aspirin were told you cannot advertise the benefits of aspirin in reducing the risk of first heart attacks. Now, I don't know about the science on this. Maybe aspirin does help in preventing first heart attacks, maybe not. But these companies were told if you try to advertise that your product may help prevent first heart attacks, you're going to be in big trouble with us. So there was a ban on aspirin advertising, causing perhaps tens of thousands of needless deaths per year. Now, what about these FDA tests? There are two ways that the FDA can err in their testing. They can reject a drug that has benefits greater than costs. That's a type 1 error, and they often do this. And then they can accept a drug that has costs greater than benefits. And if you put this into a kind of a matrix here, you could say, well, if the benefits in fact exceed the cost, then accepting the drug was a good thing to do. If they reject the drug, then they've made a type 1 error. Now, I would say you can't measure benefits and costs. I would say the FDA has no business rejecting any drug because you can't tell for sure what these benefits and costs are. So we don't really know what the state of the world is here. All right? Now, if the FDA, given that we don't know which column we're in for sure, we can't make interpersonal utility comparisons, we cannot measure all of these costs, they're subjective. Different people have different tolerances for risk. Nevertheless, we might say, well, they've committed a type 2 error if they accept a drug for which the costs exceed the benefits. Now, again, we don't know whether they will have made an error or not. And as I said in one of my earlier talks, we have to make decisions on the basis of ethics. Policy decisions need to be made on the basis of ethics. And as Rothbard would point out, efficiency cannot be a basis for these kinds of policy decisions because we don't know what the costs, we don't know what the benefits are. What about human liberty to decide what you want to put into your own body? It's your body. If I want to put some sort of chemical into my body, then that's my business. Okay? All right. Nevertheless, we can go on and we can show where simply the cost and the length of time that it takes for the FDA to make these policy decisions, accept or reject, just the length of time itself imposes costs. The consensus in the literature is that, and this includes a wide variety of economists, not just Austrians, is that the FDA has placed too great an emphasis on type 2 errors. That is, avoiding drugs that have damaging side effects. The FDA primarily seeks to avoid approving drugs with potentially adverse consequences, and it places insufficient weight on the type 1 error of failing to approve beneficial new drugs. And one of the reasons for this is type 2 errors are more noticeable. You can look back in the 1960s at the thalidomide, and this is the FDA's poster child for why they exist. They'll say, well, look, other countries approved thalidomide. We kept thalidomide out of the United States. This was a drug used for morning sickness in pregnant women, and it was discovered later that it had some connection to birth defects, rather severe and tragic birth defects. So the FDA kept this out of the United States, and from then on they've said, well, see, this is why we exist. It's very easy to point to children's birth defects and see those costs. You can take pictures of those people and you can say, that is tragic. It's not so easy to find the people who might have been helped by a drug that was kept off the market by the FDA for fear that the bureaucrats might be blamed for admitting a drug that might later be shown to have some kind of side effect. And one example of this I read some years ago in the Wall Street Journal, a doctor at the Boston Children's Hospital found that in Europe they were using a nutritional supplement for newborn children that seemed to not only prevent liver damage in those premature children, but also reverse liver damage. And this is a very serious problem for premature babies, apparently. Again, I don't know the medical science on this too much, but children that are born prematurely with immature digestive systems have to be fed through IV. It's kind of a catch-22. If you don't feed the child, that's obviously a problem, but if you do feed the child for too long with an IV, you can have liver damage, apparently. And so he found this method that was being used in Europe to deal with this problem very effectively. Well, it was only permitted for use in the United States on an experimental basis. Now, the pharmaceutical company in Europe that manufactured this did not want to sell it in the United States. Now, what kind of bizarre world is this in which a company does not want to sell a valuable product to willing consumers in one of the largest markets in the world? Why not? They did not want to go through the FDA approval process. They said, it's very expensive, millions and millions and millions of dollars, and by the time we're done, well, we've already got another product in the pipeline that's going to be better, and if we're going to spend the money, we'd rather spend it on the product that's coming up and not on an older product that we've already got. So the FDA in this case is essentially killing children, but you don't know which children. You don't know how many. You can't take pictures of the ones that would have been helped because, and frankly, most people don't know that this kind of thing is going on. If the FDA approves a drug that's later found to be unsafe in any way, the news media, the public, the politicians will start to blame the FDA for the error. If the agency delays when reviewing applications, the patients who need this innovative new treatment are worse off, and some may even die waiting for the FDA to act. Now, I was very happy to see when the lobbying for AIDS patients became quite strong, that the FDA was put under intense pressure to fast-track drugs through their approval process. We need more of that kind of thing. If we can't get rid of the FDA entirely, at least perhaps we can put pressure on them to allow people who are in desperate need of some kind of treatment to choose a treatment that they think might work without the FDA trying to stand in their way. So in both cases, whether we have a drug that causes damaging side effects or we prevent a drug from coming into the market for a long period of time. This is 7 to 10 years in some cases for drugs to be approved. We've got people who are hurt in both cases, but the FDA tends to bias in favor of keeping drugs off the market because they know that they will be blamed personally if there are demonstrable side effects from some admitted new drug. So they have this kind of risk-averse culture. All right. A little bit of history on this. In 1906, the FDA said, well, we don't want medications to contain substances harmful to your health. Now, this sounds pretty innocuous. Well, who wants to put poison into their bodies? Pretty much every medication is a poison if you consume enough of it. Okay. Now, I happened to see a certain website that you might be familiar with, LouRockwell.com, this morning, had an article on the e-cigarette, which the FDA is fighting tooth and nail, confiscating, because the e-cigarette apparently contains some sort of chemical called diethylene glycol. Start throwing, these chemical names at people, and people think, I don't want diethylene glycol in my system. I don't want dihydrogen monoxide in my system. Dihydrogen monoxide is water, right? People don't understand what it is, and so the FDA says, well, diethylene glycol is found in antifreeze. You don't want to put antifreeze in your system, do you? I recommend that you read this little article. I don't have enough time to go through it today, but if you go to the article today on LouRockwell.com and find this article on e-cigarettes, it's beautiful. It's a wonderful depiction of the problems of the FDA, basically discouraging people from consuming something that is, in all likelihood, far better for them than the alternative, tobacco cigarettes. You got something with 3 chemicals in it, which people have high tolerances for the chemicals they do put into these e-cigarettes. And e-cigarettes are some sort of battery-operated thing. They produce a kind of a nicotine vapor that you consume instead of all the others, the 3,000 chemicals or whatever it is that's in regular tobacco. This is an improvement. It's a tiny, tiny fraction of the chemical content of cigarettes, and yet the FDA is trying to keep them off the market. Take a look at that if you can. 1938, the manufacturers were required to demonstrate safety. Now, I'm going to talk about consumer product regulation later today in my 1:30 talk, and we'll talk a little bit more about this kind of thing, but one of the points I'm going to make then is there is no such thing as a dichotomy between safe and unsafe products. How safe do you want something to be? That's really an individual decision. Your risk tolerance, how desperate you are for a treatment, all of those things have to factor into your decision. But whose definition of safety do we have to use now? Well, it's the FDA's. The FDA decides how safe the chemical has to be. Then we have, in 1962, a requirement from the FDA that drugs have to be both safe and effective. How effective? Is it possible that somebody might want to consume something just on the 1 in 100 chance that it might work? The FDA might not decide that this is effective enough to allow people to choose for themselves, but an individual ought to be free to decide to take that risk. Prior to 1962, the FDA was required to approve within 6 months unless the new drug was not proven safe. Okay. Now, again, I've got a problem with them having that power to determine what is safe. But after 1962, the time constraint was removed. It's not going to be 6 months anymore. So the drug approval process was much longer. And prior to 1962, the time from filing for a new drug to getting that approved for the market was about 7 months. By 1967, it was 30 months. By the late 1970s, it was 8 to 10 years. And the testing cost went up, around $800 million for each new drug. Now, is this promoting competition? Is this promoting the welfare of consumers? To blockade new products with this immense cost and this lengthy period of time. Remember the time value of money. You put in this research and development, but now you got to go through this expensive approval process, $800 million, and then 8 to 10 years later, you might get to sell the first batch of the drug. This is a serious discouragement to innovation in pharmaceuticals. Septra. It's an antibiotic. It's been around for a while. There's a 5-year delay in introducing this to the U.S. market. One estimate indicates that this delay cost 80,000 lives. 80,000 lives. Beta blockers. Been around for a long time, too. The lag may have cost 250,000 lives in the United States. This is not a trivial concern. Hundreds and hundreds of thousands, if not millions of people adversely affected by this kind of thing. Now, once you mix the FDA with the Centers for Disease Control, you have the CDC saying, we're going to strongly push, if not require, perhaps via the public school system, their immunization requirements, we're going to push for the acceptance of some new product. And this is kind of the opposite sort of problem. You've got the FDA approving some drug, which is, I really would, again, I like for them to let things through, let people try them. But then you've got the CDC trying to push this. Rotavirus. Almost all children contract rotavirus by age 5. Rotavirus causes about 55,000 hospitalizations and about 20 to 40 deaths per year. In 1998, the FDA approved RotaShield, which was a vaccine for the rotavirus. And then the CDC recommended that all infants get this vaccine within a year of approval. Over 1 million children were immunized, and they had 2 deaths that were related, they found, related to rotavirus vaccine, and 99 cases of a bowel obstruction problem. Now, we know, or we don't know, we can guess, estimates are, that the system for reporting vaccine-related harm catches maybe 10% of the actual vaccine-caused injuries. All right, so take 2 and multiply it by 10, and we get 20. Well, rotavirus caused 20 to 40 deaths per year. We're getting close to a wash here. Now, maybe getting your child immunized for RotaShield is a great idea. maybe it's not. Who should make that decision? CDC or the parent? One member of the CDC committee that recommended that this rotavirus vaccine be added to their sort of vaccine pushing program holds a patent on the rotavirus vaccine. He was paid by a large pharmaceutical company to develop the vaccine, and he did not recuse himself from voting on issues surrounding this vaccine. In fact, several members of the FDA and the CDC committees owned stock in drug companies and stood to gain from having the government require immunization. This is not some sort of a detached intellectual assessment of the risks and the benefits. These are people with an interest in the outcome, a definite financial interest. Vioxx. There was a Lancet study revealing that Vioxx had problems. The FDA seemed to delay the release of this study. David Graham, who was a 20-year FDA employee, and this is by the way from an article by Dale Steinrich, and I've got the link to this elsewhere in the presentation if you're interested in that. But David Graham said, "What I believe they were trying to prevent from reaching the public was our estimates of the number of people who suffered heart attacks or died because of Vioxx use." He said, "I believe there were multiple levels of FDA management who wanted to keep the information of the magnitude of harm caused by Vioxx from the public and wanted to damage my credibility as a scientist." He said, "I would assume the reason this happened is because the FDA sees its mission primarily as one of serving the pharmaceutical industry, and with Vioxx, the FDA looked the other way, and we paid a price for it." Now, this former employee may have wanted the FDA to ban the substance. I don't agree with that, but the FDA is trying to play God here, as Steiner mentions. Turns out that 10 members of the FDA panel who voted for Vioxx and another drug, Bextra, had ties to their makers and were decisive in finding favor for this drug. These are not independent decision makers making some sort of decision on the behalf of the American public. Even if they had the knowledge as to what's best for the American public, which we know they don't have the incentive. $800 million for a new drug. We know that these resources could have been used elsewhere. $800 million can do a lot of things. These are just estimates. I mean, you have to take these with a salt shaker of salt. But we do know that spending money in one place means you can't spend it in another place, and that other place where you could have spent the money could have saved some lives also, if that's what you're after. One estimate is maybe $10 to $17 million. You'd reduce income by that much and you're going to lose a life somewhere, somehow. We couldn't afford to, install refrigeration in some low-income household, and so their food went bad and they died of food poisoning. We don't know exactly where that lost life is. But you lose income, you're going to lose lives somewhere. We might have a fair number of lives lost simply from that financial cost of drug approval, not to mention the delay and the loss of the access to that drug. In the interest of time, I'm going to move ahead a bit here. If you want to ask me questions about this later on, you can certainly do so. Let's look now at some bureaucracy problems. Moving away from the pharmaceutical industry per se, one of Mises' great books is Bureaucracy from 1944. It's available down in the bookstore. Government must be formalistic and rigid, he says, by its very nature. The core problem is we don't have a measure of success and failure in government. We don't have profit and loss. indicate what good uses of resources are and what bad uses of resources are. Hayek, in one of his most famous articles from 1945, Use of Knowledge in Society, says that knowledge that is important for making decisions can't be transmitted to some sort of central planner because it's not of the form that central planners can make any use out of. It cannot enter into statistics. You can't convey it to a central authority. Maybe it's too time sensitive. Maybe it's a subjective knowledge that can't be put into numbers. Not everything that counts can be counted. Can we take a doctor-patient relationship, write down the key facts of that relationship and the decisions that were made, the symptoms that were reported, send this off to some central planner, and have the central planner tell the doctor, you made a good decision or you made a bad decision? I would argue that there's too much going on in that relationship between the customer and the supplier of medical services to be able to judge whether or not that customer got a good deal or whether that supplier provided the correct product to that patient. There's too much else going on. There are too many particular circumstances of time and place. Doctors, nurses, other medical professionals cannot be effectively judged by a central planner off at Medicaid headquarters somewhere. When we try to scale medical care upward, it is necessarily bureaucratized, and all of this carries risk. We miss circumstantial information that is important. Doctors then have to choose, do I satisfy the patient and help the patient, or do I comply with the regulations? In many cases, doctors are finding they can't do both. I can make this person, help this person get well, or I can obey the regulation, but I can't do both. Conscientious doctors then sometimes will creatively bend or break the rules to help the patients. The regulators know this. They don't care about the patients. They want people to follow the rules, their rules. So the penalties become just outrageous because they know they can't catch but a fraction of the violations. But when they catch you, they'll throw the book at you. Mises, in his book Economic Freedom and Interventionism, says it's important to remember that government interference always means either violent action or the threat of such action. Government is, in the last resort, the employment of armed men, of policemen, gendarmes, soldiers, prison guards, and hangmen. The essential feature of government, he says, is the enforcement of its decrees by beating, killing, and imprisoning. And this is happening in medical care. This is an article from last year, 2009. Medicare fraud. The charging doctors with criminal charges for violating Medicare regulations. And this, what's important to understand, I think, here is the doctor doesn't have to have intended to break the regulations, and these are extremely complex. You can't even know the rules, but if you break them, or if one of your staff breaks the rule, you can lose your medical license. Licensure is something I haven't talked about, but that's a whole other problem. So the government's relying on Medicare data analysis to try to detect fraud, what they call fraudulent billing. I mean, fraud, in my view, requires some sort of intent to defraud, not just a mistake. But you have a coding error, and all of a sudden you can lose your medical license. So, former office manager for a medical practice in Michigan, Edgardo Perez de Leon, convicted of 12 felony counts of Medicaid false claims and healthcare false claims offenses. He coded patient visits that did not involve a physical examination as office visits. The coding, he thought, was the closest match he could find to the Medicaid manuals. A physical examination is not necessarily required on every occasion. He spent a year in jail. The family house was threatened with foreclosure. Their children were sent back to Puerto Rico to live with a family because they couldn't afford to support them. He was never able to figure out what the government meant by an office visit. Now, one of the organizations I'm getting some of this information from is a great doctors organization called the American Association of Physicians and Surgeons. If you haven't heard of them, it's a fantastic group of people, the AAPS, and very, very favorable toward free markets, a great alternative to the AMA, which is decidedly socialist. My father, incidentally, was the president-elect of the AAPS before he passed away last year. So I've got a personal interest in this, yes, but it's a really fantastic group of doctors. And they found in one of their surveys that the system's very structure made fraud easy, made unintentional errors virtually unavoidable. 82% of doctors said they feared they had an increased fear of prosecution or investigation than 3 years before the study. 71% said they're making changes in their practice to avoid threat of prosecution. They're restricting services. More than a third are restricting services to Medicare patients. They just don't want to take Medicare patients anymore. It's too risky. 20% of those said they don't want to take Medicare patients because of hassles or threats from Medicare. Only 16% of them said, well, it's because the Medicare fees are too low. Although that's probably going to change with the current system. Almost a fourth don't take any new Medicare patients. A few who do only do so under special circumstances. I'll skip some of the rest of this. But this is one of the things that's interesting here. Say you're a doctor, and you're trying to do what's in accordance with the regulations, so you can avoid trouble. 85% of the time, Medicare customer service representatives gave the wrong answer to questions posed by physicians regarding the proper way to bill Medicare. These were people on the other end of the line. I hate calling this customer service, like this is some sort of voluntary transaction, but that's what they call it. So we'll let it slide for now. 85% of they knew, the customer service people knew that they were being tested. They knew that they were under scrutiny. This is not some sort of surprise. And these are not difficult questions. These are questions that would be normal for them to be asked. 85% of the time they're getting it wrong. So the government said, well, we will improve. We'll do better. A follow-up study 2 years later found that 96% of the time they're giving the wrong answer. They're so confusing. The regulations are so confusing that the professionals, the professional bureaucrats who are supposed to be able to interpret the regulations are incompetent to do so. And then, of course, when a doctor gets in trouble, who do they call upon to interpret the regulations in the courtroom? These same people. The Medicare bureaucracy is such that the incentives are, let's cycle as many people through the system, if you're a hospital, because they're paid by the diagnosis, not for anything else, just the diagnosis. You get somebody in diagnosed with renal failure or something, that limits how much the hospital is paid. So the hospital wants rapid turnover. The doctors, on the other hand, have incentives to keep the patient in the hospital for a long time so that they can do more tests, do more procedures, because the doctors are paid by Medicare and Medicaid by their procedure. Does this balance out? Incentives to stay too long, incentives not to stay very long at all? Well, in a lot of cases, you've got people who are there for too long or not there for long enough, and it rarely balances out for individual patients. Now, I found an article, and I hope you will read this if you have an opportunity. This is the June 2010 Free Market front page article by Boyapati on the economics of healthcare reform. And I'm not going to go through this, but in the interest of time, but there's so much here where he's pointing out some of the reasons why we have rising medical costs. One of the keys is that people are not paying out of pocket for their medical costs. So they have very little incentive to watch those costs. There's a third-party payer system, heavily encouraged by a combination of high taxes and deductibility for employer-provided medical insurance. So we have a distortion in the market created by this system of employer-provided health insurance, plus systems like Medicare and Medicaid that are also third-party providers. Then we have licensure, he says, which restricts competition. We have an obesity epidemic, and before I read the article, I have to confess, I thought, well, maybe Americans are just, we eat too much, just some sort of cultural thing. And that's our problem. What do you do about culture? Well, and try to raise your kids not to eat too much or something. Well, Boyapati points out that part of the reason for this may be that we have a heavily subsidized corn industry in the United States, which encourages the Americans to consume a disproportionate quantity of calories in the form of high fructose corn syrup and other corn-derived sweeteners, which lab tests indicate are much more likely to fatten you than pure table sugar, sucrose. The cheapest calories in the grocery store are the least healthy. Not because grocery stores are out to kill you or McDonald's is out to give you a heart attack. That's not the reason. Why are the cheapest calories in the United States the unhealthiest? Well, they don't subsidize carrots. They subsidize corn sweetener, effectively. Anyway, you can read more on that, but then there's the intellectual property thing that I've already mentioned. So why do we have rising costs? And then if you look at certain areas where the government intervention is not as severe, Boyapati mentions LASIK eye surgery to correct your vision. It says costs have been dropping, quality has been improving in that industry. Why is that not true for other parts of medical care? Okay. If people are having a third party provide the service or provide the payment, they don't have the incentive to watch the costs and make sure that the cost and the qualities sort of match up. If I've got somebody paying for, I have to have vision correction. I noticed in Walmart the other day that I could have single vision glasses, which I wear for, Walmart says, about $40 if I want. Or I can get eye surgery for, maybe $3,000 or something. Now, my decision is affected by the fact that I have an employer-provided plan that helps a little with the cost of eyeglasses. I've got one of these flex spending accounts. So my costs are for things like eyeglasses are sunk. My marginal cost for eyeglasses is greatly reduced. So I tend to go a little more expensive than I would do otherwise. Anyway, think about that because that's, I think, important. We look at these rising costs and we think, well, the medical care system is broken, therefore capitalism doesn't work. Again, this is not at all correct. We've got another tier of institutions, insurance companies and government, putting themselves between the consumer and the provider. So care providers start to work for the satisfaction of the regulators, work for the satisfaction of the insurance companies, and not for the patient. We've got this complex system now. There's the patient way up there who wants to get something from the care provider and has got certain quality standards of his own. He wants his problem fixed, whatever it is. But then the care provider's got to think about the requirements of the insurance company and the requirements of the government, and of course the patient is trying to get insurance through the employer. There's a risk pooling issue here, which I won't go into. But where is the money coming from? That will determine where the care provider's, or what the care provider is going to pay attention to. Here's the patient standards. All these different requirements back and forth, lobbying from the insurance companies to the government. lobbying from or voting from the patient to the government. People have this kind of myth about voting that, oh, voting is going to magically produce good results. Far from it. If I had time, I'd go on and I'd talk about what the voters selected as the Democratic candidate in my state, South Carolina. But I won't do that now. Efficiency standards from the government, from the insurance company to the care provider. 40 to 45% of the money is coming from the government, at least. Not to mention all the regulation. 40% coming from insurance, and only about 10, 15, 20%. I put this up as 15 or 20%, but somebody told me later it's more like 10 to 15% coming from the patient. Who is the care provider going to listen to? We get a tremendous moral hazard problem whenever there's a third party. When government's providing something, you don't tend to pay much attention to the cost. It's not your cost, somebody else's cost. Taxpayers, somebody else, some anonymous person that the government has confiscated money from to pay for your medical care. In fact, it's a waste of your time and energy to try to look around and be a good consumer, a good shopper, and try to reduce your costs. Because they're not your costs. Now, people have said, well, we need to regulate insurance companies because the insurance companies are denying claims at a high rate. Medicare denies almost 7% of its claims, which is higher than any private insurer. We think government's going to somehow improve the situation by reducing the claim denial rate. We also find that in countries that have a more severe level of government intervention than the United States. I'm not going to say that this is some sort of comparison between a market-driven system and a government-driven system. But in systems where the government is a more dominant force than it is even here, you get measurably lower quantities of some of the technologies that we tend to think probably help people's medical care. Fewer physicians, fewer nurses. We noticed that the costs for Medicare and Medicaid are rising faster than the costs of private health care. And this is one of the arguments for the latest government takeover of medicine. Well, we're going to try and drive down costs. Really? Because you haven't got a real good track record of that so far. And this is in spite of the fact that let's see, I've got a here we go. Cost containment record. The two biggest medical care programs that the United States government runs, Medicare and Medicaid, their costs since 1970 have risen significantly more than the per-patient costs for every other health care system in the United States, in spite of certain advantages that they do in fact have. This latest government takeover is supposed to be cost containment? Oh, we'll just do it bigger. We'll have more socialism. See, the problem was we didn't have enough socialism before. It's nuts. I get a little worked up about this. Again, you look at MRI machines or some sort of definite technology that we think more access to MRI machines is probably not a bad thing. We have almost 5 times as many MRI machines in the United States as they do in the UK, and close to the same availability difference with Canada. We have a whole lot more CT scanners per million people compared to the UK and Canada. The UK has higher rates of death from heart attack, stroke, and cancer than the United States. Canada has higher rates for heart attack and cancer, not stroke. We're told sometimes the United States has a lower life expectancy than some of these other countries. And see, that's because we have a system that's more oriented toward markets. No. There are other things that affect your life expectancy besides doctors and hospitals. Accident rates tend to be much higher. You're going to blame doctors and hospitals in a free market, not free market, you're about to make the same mistake, a more market-oriented system for life expectancy problems. because of things that are happening before the patient even gets to the doctor in the hospital? Cancer survival rates are better in the United States, significantly better. 5-year survival rates. And then if you look at wait times, this is commonly cited, and you've probably seen this information elsewhere, but I think it's important to point this out. Now, this may take a little study before you understand what this graph is trying to show you, but basically what this says is if you look at the wait times that are relatively short to see a specialist upon referral from your primary physician, short wait times are more common in the United States than they are in countries that have more socialism rather than less. I don't know what's going to happen after the current takeover takes hold. I would guess that number would drop. This is from 2008, so we'll see what happens. But in a number of these other countries, Canada is a good comparison, 40% of the patients are waiting less than 4 weeks to get seen by a specialist. Now, what about longer wait times? In the United States, 10% of patients are waiting more than 2 months. In countries that have more socialism in their systems, the wait times, the longer wait times, tend to be a much larger fraction of their patients. It's not going to help your quality when you have to wait. You can come up with all kinds of anecdotal cases, which I don't have time to go into here. People who are waiting so long for a surgery that by the time they get into the surgery, it's too late to do the surgery. Their medical condition is deteriorated, not to mention the subjective cost of all the suffering and pain that they go through while waiting. The essential, the standing in line aspect of all of this. So this can be expected to go up. These waiting times can be expected to go up as government increases the level of bureaucracy and increases the extent to which they pay for medical services rather than the patient. Now, I could not resist this, and I know I have one or two people here from the UK, so I have to pick on the UK just a little. We've got the British here pulling their own teeth because they can't get access to their free dental care that they have in the UK. They can't find one, they can't afford one. 6% of people questioned in a survey of 5,000 patients admitted that they had tried pliers and glue to treat their own dental problems. Now, they have a two-tier dental care system. Some dentists offer publicly subsidized treatment through the National Health Service, which you can't get because you can't find these people, or the waiting lines are too long. And you know, if you've got a hurting tooth, you don't want to wait. It hurts. You're incapacitated for a while. And then you've got others who are performing more expensive private work. So, more than 3/4 of those polled said they had been forced to pay for private treatment because they had been unable to find a government dentist. About a fifth said they had refused dental treatment because of the cost. One respondent says that she extracted 14 of her own teeth with a pair of pliers. I took most of my teeth out in the shed with pliers. I have one to go. Yeah, okay. Others said they had fixed broken crowns using glue to avoid costly dental work. Valerie Halsworth, age 64, told British television she had removed 7 of her own teeth using her husband's pliers when her toothache became unbearable and she was unable to find a National Health Services dentist willing to treat her. Chair of the Commission for Patient and Public Involvement in Health, who commissioned this survey, says, these findings indicate that the NHS dental system is letting many patients down very badly. You think? I don't know. Pulling out your own teeth with pliers, I mean, how bad can that be, right? Now, to wrap up here, and I'm out of time, but I'll just say there's so much that you can read on this. If you want more, I can give you some sources. You'll run into this kind of thing very often in your undergraduate and your graduate studies, where people are saying, well, maybe markets are good for making widgets, but they're not so good for medical care because medical care is some sort of right. Now, I haven't had time to get into the ethics of all of this, the rights people might have to medical care. I will point out that if I have a right to medical care, that is equivalent, it's inseparable from saying I have a right to have the government to stick a gun to your head and pull money out of your wallet and give it to me, which is to say that my right to medical care, if such a thing exists, is equivalent to a denial of your right to your private property. You cannot separate those two things. You have one or you have both, or you have the other, but you cannot have both. All right, well, I'm done. I'll answer questions happily outside. Thank you.